This episode of GT the Podcast is supported by Alcon.
Dose and delivery.
Welcome to Dose and Delivery, a new podcast series on GT the Podcast. In this episode, Drs. Nathan Radcliffe and Stephen Sarkisian join Dr. Paul Singh to discuss how their approaches to glaucoma management have evolved over the past few years, including their use of a bimatoprost intracameral implant. More on this from Dr. Singh.
Dose and delivery.
Hey everybody, welcome to the first Dose and Delivery podcast edition of 2021. I'm Paul Singh from southeastern Wisconsin, and I'm here and I'm lucky to have two awesome friends, surgeons, educators, just cool, awesome people. Nate Radcliffe from New York City area, and of course, Steve Sarkisian from the Oklahoma City area. What's up, guys?
Great to be here, Paul.
Thanks for hanging out, man.
We're really glad. This is gonna be fun.
We are so pumped. So when they're like, "Hey, man, we gotta think of our first episode. Who do you want on it?" I'm like, "Oh my God, I gotta have Sark and Nate." I mean, it's just like a classic. We're talking a little about drug delivery. There's no doubt it's gonna be some fun talking about all the different options that we're having now and what's gonna come down the pike. But man, I just want to start off by saying, how you guys doing now? I mean, you guys back real quick. I don't want to spend too much time on COVID, but you guys back in action? Anything different now that's kind of stayed with you since the beginning of COVID?
I mean, for me, it's interesting because this is my second year since I've founded a practice, and so it's if I had founded it the year before, I would have been in. If I had founded it in 2020 and not instead of 2018, end of 2018, I would have been in big trouble. So God is good there, and and I think in Oklahoma City we're pretty much, with restrictions, pretty much back to business 100%. So
nice. Anything that's changed, anything that you did, like do you do more telemedicine now? Do you do drive-throughs anymore? Do you like more kind of hybrid visits? Anything that's kind of stuck with you?
it's nice to have an empty waiting room. People waiting in their car.
You don't know how many people you have left in the day. You're like, oh, that's not so bad. And all of a sudden, like, oh wait, there's a list of people outside, a line of cars, man. Nice. How about you, Nate? What's going on with you guys out there?
I would say I got my first 6-week vacation earlier in the year of my life. So that was how we started the year. And now we're busier than we were in 2019 even. Somehow New York is sort of back with a vengeance, which, is good. We have good systems down. Everyone's pretty comfortable with it. It feels normal. And the one thing I would say is not a day, passes by without me seeing some patient who says, hey, sorry, it's been 9 months. I didn't feel comfortable coming back in. Now I've been vaccinated. And then I say, do we get this guy his refills? Oh no, remember you did that laser and I haven't, let's see how my pressures are. And, SLT to the rescue. And it kind of has reinforced a lot of the strategies that I was sort of believing in, but hadn't been tested before the pandemic, just about how important it is for our therapies to be meaningful and sort of bulletproof, compliance-proof, pandemic-proof, whatever word you want to use. It kind of made me feel even more strongly that we need to be doing standalone MIGs, SLT, sustained delivery, all this stuff that we talk about all the time.
This is one of those other arguments for first line SLT or first line Durysta. I mean, it's a perfect segue because we really, during these times, want to be seeing some of the patients we were maybe seeing every 3 months or every 4 months. We really want to be seeing less frequently. We don't want to have our waiting rooms crowded with people that are stable or that are just on meds, and really they don't want to be exposed unnecessarily either. So I'm always astonished that we're still talking about primary SLT as a treatment, and considering I've been doing it almost my whole career, but I think that the argument can be made that in times like when they're high risk of infectious disease types of things, it's a good way to go to help make it not only perfect compliance, but not having to necessarily have to have a bunch of staff dealing with refills and all those kinds of things as well.
Yeah, no, I mean, you guys have brought up some fantastic points. Yeah, I agree with you, by the way. I saw a patient just this afternoon, one of those guys who finally got his vaccination. He came back in and he would literally, he had like a nasal step and now has already lost some fixation. I mean, it's ridiculous in 9 months, like you were saying, how quickly some of these patients can progress. You're like, oh my God, if I just didn't have to worry about these people, it makes you feel horrible about it. So I agree. I think we've had a lot of options now. I mean, we got SLT, drug delivery. We have obviously a plethora now of MIGS, standalone and with cataract surgery, and subconj MIGS. So let me ask you guys, just real quick before we get into more details, what are some of the philosophical changes that you've seen in your practice in the last, let's say, few years versus, let's say, 10 years ago? And you guys are old like me now. So what are you guys' thoughts on what's changed in your practice mentally and how you approach glaucoma?
I think, look, when I stopped doing trabeculectomy 10 years ago, that got me nothing but funny looks. Maybe it was even a little longer. And now I think at least if not the practice of avoiding trab, the notion that there are other things to do in a lot of cases where in the past we might have done trab has sort of grown. And, that has, look, for the ICE procedure, when I started doing iStent, I started right away with ECP. It just combo MIGS, from the get-go. And my goal was to fill in that gap. And, I learned about the gap from Ike. It's the gap between medications, which are nice, but don't always do the trick and have tolerability problems, and things like trabs, which are, overkill in some cases. We have all these gap therapies now, many, many, many therapies, and we're all getting to know them and getting to use them. And it's just, this space has just exploded in a great way for patients.
What about you, Steve? I mean, do you feel like when you look at a patient now who comes to your office, is your mind first thinking about an intervention in general, or are you even thinking about drops at all for most of these patients?
I've always been an interventional glaucoma specialist. I mean, I'm that's what I set out to be from the beginning, and I've what it takes is to train my strategic partners and my referring doctors from the beginning. And I'm in Oklahoma where optometrists can do SLT. And so, and I'll tell them, just do your thing, but I'm here for you. Like, I'm here for you. Ask me anything. You're never bothering me. Text me, whatever. So I'm their safety net, so they can play with the drops and do whatever they, and even do SLT. A lot of them still send me though. I've trained them that that's first line therapy, and they're happy to do it. And so that's how my practice differs, is that I've for a long time, from the first lectures I was giving the year after fellowship, saying glaucoma is a surgical disease, and it's become a sort of joke that I've gone from pariah to prophet, because by the force of the collective will of the MIGS mafia, we've brought that to bear. Right. And the technology we've produced it, and we haven't broken kneecaps. We've produced good data, relentlessly produced good data, and thought differently about things, and said, well, look, why do you have to make a home now? Why can't you do a canal surgery and an ECP? And the naysayers would say, well, no, you're destroying perfectly good ciliary body. I'm like, well, then stop using all the aqueous suppressants that you're using. They're suppressing the aqueous.
We're destroying all the epithelial cells and all the goblet cells. Who cares about that?
Right. Like, do you understand what you're doing to these? That you're already doing by keeping people on eye drops for 30 years and pretending that they're taking them as you say, and that's the real pernicious thing, right? Is that it's this delusion that our patients are compliant, and we think we know who's compliant. Taking the time to talk to patients about compliance is one of the joys. You'd think, well, you're trying to get through a busy clinic day. No, talk to your patients. One of the joys of life is talk to your patients and get them to open up about their problems and their issues with drops. And then you have tools now to set them free, and set your staff free from dealing with phone calls from insurance companies saying, I'm sorry, that one's not on formulary anymore. And, can you switch it to this one, please? Because, our cut is better on that one, and this really applies to all the things we're going to talk about tonight is the honest truth about what we're really what we're up against. this is what we're up against. Is it's not just the people that are have difficult, the other doctors convincing them that that we shouldn't start with trabeculectomy, but really it's taking good care of our patients.
So so good point. I mean, so here's what I want to ask you guys, and I think that there's a lot of our colleagues who I think appreciate now. Okay, fine. Earlier intervention makes a lot of sense. We do have SLT, we have our MIGS. Now we have drug delivery. Of course, Durysta was approved last year. I know all three of us have done a lot of these cases, Durysta cases now since June, and a number of 6 months, 8 month, 9 month follow-ups. But I guess my question is, before we get into that, how are you helping yourself and how are you helping educate patients to know what to do in what situations? For instance, like I know one of the biggest pushbacks I get from doctors is, well, look, for drug delivery Durysta, I need to find that right patient. And so let me ask you guys, is there a right or wrong patient for Durysta, or is it something that you say, hey, look, drug delivery can help in a number of patient population, whether it's mild, moderate, severe. So talk me through that conversation you have with yourself and with the patient, how you present drug delivery Durysta in this case, and what are the kind of patients you've seen that's helped your practice? Nate, what do you think?
Yeah, so it does depend a little bit who I'm talking to and what I think their comfort level is with the injections. If it's someone who I know does a lot of injections, is comfortable refilling ACs and phakic eyes that have had an omid valve, for example, that's going to be someone different where I'm talking to them and it seems like their major hesitation is they're just worried about the injection. So I don't think, there's so many diverse patient types that we can treat with Durysta, from 36-year-olds, who are toxic on meds, to very old people who have their children putting their drops in and need to let their children go home at night to take care of their grandchildren. So you can give Durysta and spare a family member the need to come by someone's house to put drops in. I often tell patients or doctors about patients who I think are following the sweet spot. And again, if a doctor is worried about the endothelium, I push them towards pseudophakics and older pseudophakics where it's really unlikely that the endothelium is going to face any challenge in the remaining X number of years of someone's life if they've already had uneventful cataract surgery and now have a deep chamber. So I will say, yeah, look, you want a sweet patient, take an 80-year-old on 3 drops who's pseudophakic and had uncomplicated cataract surgery by you 10 years ago. They'll tolerate it. There's plenty of room for the implant. They definitely have dry eye if they're on 3 or 4 bottles, And there's undoubtedly they're tired of taking the medications and the surface of their eye is paying for it. So those are happy patients. The injection in my hands always goes well. Patients are thrilled after. But absolutely, I could turn around the next day, find a phakic 35-year-old who needs help and take care of them as well.
No, you made some good points. And Steve, I think you made a good point earlier about listening to your patients and talking to your patients. Like historically, we're like, damn, I don't got time to talk to my patients because I'm so busy. I'm like, I don't want to hear that they're not taking meds. The pressure's good right now. Fields are fine. See you back in 6 months. But now when you do talk to these patients, you actually can, I think, uncover a lot of the compliance issues, whether it's cost, side effects, forgetfulness. I just can't take these anymore. My eyes are always irritated. So let me ask you, do you trigger off of a patient's complaint and say, okay, this is someone who I can now talk to about Durysta or SLT, or are you on your own kind of trying to find that patient? Or are you listening to them first?
So people ask me all the time, well, I'm just struggling to find a patient that I would do Durysta on. And I'm, 60% of glaucoma patients on topical medications have ocular surface disease. Maybe it's higher. I don't know.
It's higher than 80% of my practice. I'll tell you that much.
Right. And of course, we all have a referral bias because we see the worst. But it's like, well, why don't you have a talk with these people who all the visit is spent talking about their dry eye. And I'm at the point now where I don't really see those folks anymore. I'm like, your pressure's control. I'm gonna have you see my dry eye specialist so that I have, one of my medical residency trained optometrists, that's what they do. And I'm just like, you're going to see them and I'll see you once a year or once every other year, whatever, or when you need me. But I'm actually starting to see them, more frequent. They're actually being sent back to me by my optometrist because they're like, this patient's dry eye is just terrible. Can you please do Durysta? And you just ask this question. Hey, if you could, I really need to aggressively treat your ocular surface disease. And what I really want to do because they're already on cyclosporin, they've already had punctal plugs or whatever. I mean, like, when they're getting to like amniotic membrane level, like, then I'm like, you know what? Which is actually more frequent than it's a great treatment. So it's like, well, you know what? Let's stop the assault on your corneal surface. Let's do Durysta. It might last 6 months. It might last 2 years. I mean, there were patients in the clinical trial that 24% of patients that after 2 years didn't need rescue therapy.
Absolutely.
That's
With one implant. Yeah, just one implant. Yeah. Think
about that. I mean, that's huge. And now that's not typical, but 24% is 24%.
Yeah.
And so, I mean, that's the data. And so getting them off the drop so that you can do the amniotic membrane, put them on a short course of, the mildest topical steroid maybe for a couple of weeks. Just do what you got to do to heal them, get them seeing better, get them feeling better, and then watch them closely or with your team. And then if you got to do something else, then you can have a conversation. Well, do you want to do some SLT now, or do you want to restart one drop? Do you want to be on maybe, some preservative-free stuff, maybe get access to compounding pharmacy. If you need to be on more than 2 medications, they can put things into one bottle. I mean, there's lots of different ways of doing this, but people, this is the patient. All your ocular surface disease patients with glaucoma, that's your Durysta patient. Like, joyful Durysta patient.
Yeah, no, I think you guys made some great points. I think for me, what I boil it down to is like Nate was saying earlier too. And, there's no one right or wrong, kind of like find the right patient. And I think to me is clue in on a patient's compliance issue. If there's a barrier to compliance, whatever that might be, that's my trigger. And that's where I can offer them a solution. I can say, yeah, you have an issue with forgetfulness. Don't worry. Let's try this SLT. Let's try MIGS. Or a lot of times they don't want MIGS. Let's say try Durysta in this case, right? Try Durysta, even if it's not going to last you more than 6 months. Let's say it lasts you 6 months. We gave you 6 months off. Let's say they're complaining of cost, right? Oh, I can't pay that $20 copay for latanoprost. Well, look, man, if you're Medicare Part B, you got a supplement. It's no cost to you at all, out of pocket. Let's do it. And if pressure comes back up in 6 months, I saved you 6 months of paying for latanoprost, right? So I think whether it's cost, side effects, I think it's us listening to the patient and now saying, I have a solution for you. So it's not convincing them. I think it's, look, this is a simple in-office procedure. Are you guys doing it with the slit lamp, I'm assuming, as well, right?
Yeah.
So, having it in the office at the slit lamp changes the bar for acceptance and for success. If a patient says, I have to go to an OR for this, it's a different level of the definition of success. If it's in the office at the slit lamp, they're like, hey, man, that was so easy. It was like an IOP check. They're like, fine, if it goes back up in 6 months, thanks for that 6 months freedom. Nate, you were going to say something?
Well, you're making the point. I realized, recently, look, I'm the world's biggest SLT fan, but Durysta is easier on patients than SLT. It's quicker. They have fewer side effects. I never have patients coming back with the type of symptoms. I did a bunch of second eye SLTs today, and, a few people that I didn't treat with an NSAID probably could have used one. And, I don't have that type of complaint after Durysta. And I'm realizing, look, it's quicker, it's faster. I do bilateral Durystas because if I just do one eye, the patient says, I don't want to come back for nothing. Just do nothing on both eyes. And, so we switched to bilateral. But I did want to we have the three of us here, probably several hundred injections between the three of us, if not more. We're 6 months out on many of our patients. I know what I'm seeing, but I'm curious to hear how long is it lasting? What's happening in the real world? Because, we've got that experience here.
Well, I can tell you it's pretty phenomenal. We've done like 60 or 70 of these things now, even more, and about 20 or 30 of them are already 6 months out plus. And I've only had, I think, one patient I had to put someone back on. It's pretty. Now we've had a couple where the pressures maybe kind of gone up a couple points, but to me. So yes, I think majority of my patients, they're lasting 6 months. I'm saying come back in 4 to 6 months. We'll see what happens. Because in the trials, we didn't see it go back up to baseline right away. It slowly crept up. So there's some patients who are like, yeah, they're about a point or two higher. But I'm like, what? Let's just see what happens for a few more months. So I've been truly surprised more than the studies that we're seeing the longevity that we're seeing clinically. What about you guys? You guys seeing the same effect, or are you guys having to put people back on stuff now?
This episode of GT the Podcast is supported by Allergan.
Yeah, it's been impressive, and I mean, this is not this is a it's not a this is one of those talks where we can kind of talk about what we're doing, so and I mean, I've had a bunch of folks that I've done a second injection. It's off
Me
label,
too.
but
Yeah.
I've said, look, a lot of these folks that just cannot be on drops, will not be on drops, and it's surgery or and they failed SLT, so it's basically some type of incisional surgery or Durysta, second Durysta. And I'll quote, I think, Nate, I heard you say this for the first time, endothelium can be replaced, optic nerve cannot, and I quote you all the time, because that's the truth. And I promise you that you're going to have a greater endothelial cell loss with any incisional glaucoma surgery compared to doing Durysta.
Even a trab, which has no foreign
Yeah.
body in there, you loss. I mean, much more loss.
Anything that has flow dynamics within the eye,
Yeah.
Absolutely.
even just going to the canal, is going to have greater potential for endothelial cell loss than a Durysta. So that argument, I think, is stupid. We don't work for the FDA. The FDA, that's just like what the company could say. It's off. Yes, it's off label. But this
I'm gonna cut you off as moderator, because I want to tee up on this, because Nate and I we had to talk about this a few weeks ago, right? We're talking about, how do you feel comfortable doing something off label? Because that is something that a lot of our colleagues push back at us. And I know, Nate, you and I talked about doing off-label drug delivery, right? Talking about Dexicue in the intravitreal space, and we can talk about that too. But in terms of even Durysta, doing a second one, it's not on label. Talk about your comfort level and help ease the stress from other colleagues out there about offering this. So Nate, Steve, what are your thoughts on that?
So, John Berdahl says, when he talks about doing standalone iStent, I didn't take an oath to an insurance company. I took an oath to my patients. And I love that concept. And it applies here. It's not the FDA that I need to make happy. And, off label, if you've ever treated someone with an antibiotic after cataract surgery, if you've ever treated a corneal abrasion, you've used off label therapies, because there's nothing FDA approved for, corneal abrasion. And so we have been doing it since the first day of residency. And if it's the right thing for a patient, you get informed consent. You tell them it's off label. And then you proceed to do what you and the patient agree is in their best interest. And interestingly, as I found, when I got Durysta injections, second injections approved by insurance and paid for, because we asked for prior auth. They assessed our reasoning. It seemed reasonable to them. And, we all agreed it was an off-label therapy. It was a patient who made it a little bit more than 6 months on their first injection, and then came up, and I thought, they did so well. Let's bring them back down. Beautiful deep anterior chamber, good positioning of the first Durysta, approved, injected, patients off to the races. And I'm hoping we can get to that critical mass of intraocular bimatoprost, where they get the uveoscleral remodeling and have a sustained, 2-year, 3-year pressure drop. Because I think that is kind of the holy grail of sustained PGA intracameral delivery.
Yeah,
absolutely. And I'll take it a step further. I don't disagree with the FDA's decision. I think that we should have pause when we do before we do anything. I mean, we should take it very seriously, but we shouldn't allow it to restrict us. And insurance companies should never tell a doctor who's using his best judgment to save a patient's sight that they should or shouldn't do something. And it's one of those things that people need to kind of get over about, because look, if you think about chewing aspirin if you're having a heart attack, well, that's not FDA approved, but I promise you every doctor is going to grab an aspirin and chew it if he's having a heart attack. That's not FDA approved. I mean, like, come on, let's think about this. You have a license to practice medicine and surgery, and you have a brain, and you care about your patients.
I love it, man. Straight up, dude. You're like straight up. I love it.
Come on.
You can't be sorry, straight up, man. I love it. But no, it's the same thing, right? Look at intravitreal and anti-VEGFs for so long were off label, man. All of our colleagues in retina were doing it when it was off label, and it made sense because we had some studies that showed it, supported. So I wanted to bring that up because I think there's a lot of things we do, and I think whether it's Durysta or other products that we have in the future, using it off label, I think is something that people should consider if that is the best option for that patient. But going along this concept of using Durysta, how do you use it within the construct of our other modalities? So how do you pigeonholing this, or how you start positioning Durysta in drug delivery in general within the construct of MIGS? Like, are you doing it before MIGS? Do you do it after? Do you feel like it helps you kind of get patients' mindsets ready for a MIGS procedure? Let me hear what your thoughts are on that.
The conversation often was, do you want to do SLT or drops first? Now it's, do you want to do Durysta or SLT first, or drops? And, drops is an afterthought, and now I think, some people would argue that maybe their patient biases about glaucoma therapies are regional. People on the coast tend to be more conservative when it comes to medical decisions, which is interesting, isn't it? But last city in the country to do phaco was San Francisco, to adopt phaco. So it's just the way it is. And so I think, and then when you do a mixed procedure, and you need, when you want to, instead of restarting drops, doing Durysta is a good next choice, because that's really, the patients often are disappointed. If they do have to be restarted on medicines, they're like, well, I really want to be on drops again, or I thought I could get off drops. And well, now you could say, well, there is an option for you. We could do this instead. And that has been so well received. Even if, and I'm honest with them, I'm like, well, it might not last long, but we could, we'll see what new technology comes out between now and then. And things are happening so fast, right? And we need to hold everything very loosely and be very humble and realize that everything could change like in an instant when something else becomes approved and we have new tools to use.
Nate, what about you? That's great stuff, man. Thanks. I mean, Nate, what about you in terms of, do you find that Durysta, or having this option of Durysta, let's say even before you do a MIGS, has helped patients feel comfortable saying, yeah, I love being off of medications, I want to do a MIGS procedure now? I mean, has it helped you kind of convince patients, hey, MIGS might be a better option for you going forward, or has it helped you in any way?
Well, so I think, I've used it all over the place. I've used it in eyes that have already had a tube. I mean, no brainer, right? I've used it in all sorts of eyes. I place it in the sulcus in some eyes, and I can confirm it can work great back there, particularly in an eye that has some PAS to the capsule, and where when you put it in the sulcus, it can't come back forward, because some of them will. But here's the thing I think we're also doing, Paul, is we're training ourselves a little bit. And, the way I saw patients when I got out of training was go through the day, prescribe drops. If that's obviously not working, book a major surgery. And now the day is like, you've got your whole, 15 color paintbrush kit, and you're going through and using everything you've got. And viewing Durysta as one of those interventions helps get me in the mindset of, and there are other interventions too. When this wears off, instead of this, I can offer them standalone MIGS or Durysta. And then when the Durysta wears off, the standalone MIGS has already been discussed. So I think it is part of that interventional mindset. It kind of helps everyone get closer to, but the doctor as much as the patient, because I do think we all know the biggest untapped group of patients we can benefit in our practice right now are pseudophakics on drops candidates for standalone MIGS. And we have the standalone MIGS to do it. We've canaloplasty and goniotomy. It's go time. And I would argue the only thing that isn't there yet are our brains. And I think we need to change, I've written about this, we need to change our behaviors. And the way you do that is by questioning as you go through a day. Today isn't going to be like 5 years ago. I've got new options. And so once you start going SLT and then Durysta piles on, and then standalone MIGS is the next big one to fall. And then, yes, of course, this can bridge one standalone MIGS patient between procedures and, can come after a standalone MIGS. Let's say one doesn't work. Then you've got to, there's all sorts of different sequences. But I think to Steve's point earlier, it's more about just making this commitment to no longer making excuses for eye drop tolerability problems, no longer looking the other way on dry eye, no longer ignoring compliance, and just recognizing that it's sort of up to us to be the problem solver in that situation.
It's funny. We always say, oh, the patients prefer drops first. That's what they think is first line. Well, actually, most of my patients say, what do you think? We're telling them what is considered first line now, and what is the standard of care. And I say, in my practice, drops are not first line for every patient. Not at all, whether it's SLT or Durysta or even a startup MIGS right away. So I think we dictate that, and it comes from our confidence level in that mindset of intervention. The reason I brought this up about the whole, does it help you or the patient? I've had a few patients, not a lot, but a few patients come back where I initially thought, look, let's try a canaloplasty, let's try a KDV or something else, right? And they said, no, doc, at this time I want to wait. So okay, fine, let's do a Durysta instead right now. Well, they came back at their 6-month visit, and they're like, still controlled. And I said to them, okay, next time you come, we'll have to wait and see what happens. If it goes back up, we'll have to put you back on drop. She was like, you remember that surgery talking about last time? I think if this Durysta wears off, I'm ready for that surgery now. And so the patient was like, I like this thing, man, not being on drops. So it got them thinking about, how do I maintain this world afterwards? So I'm not saying it's going to convince every patient to consider a MIGS, but it's just kind of interesting. I've had a few of those now where I'm like, okay, well, when it wears off, there you go. We'll try our MIGS of choice at that time. So that's why I brought that up as well. But, in general, this philosophy of being off medications and stuff like that, I think is important, but I think there's also the fear of what do I do next? So let me ask you guys, now that you have had this 6 months follow-up, Nate and Steve, how are you following them up now? So there's 6 months. What's the next visit for that patient, and how do you decide that?
Yes, sure. I go 3 to 4 months depending on severity, but I agree. I mean, you're already that far out. They're doing well. You're not going to see them back in 6 weeks or 2 months. You're going to continue with reasonable intervals. Probably not another 6 months. And I think, to your point, everyone's so scared they're going to put this Durysta in. It's going to wear off, and the patient's going to say, well, now what? Where's my second one? What do you mean I can't? What I have are, first of all, grateful patients who are really happy, and they're happy for those months. When it wears off, they're going to be like, that's a bummer to go back on drops, but that was great being off them. No anger,
Yeah.
So just get it out of your mind that a patient whose Durysta wears off is going to be upset with you. They're going to love you. And I agree, you've built trust with them. You may re-inject, but that's sort of the experience. And I think we forget to tell the story of how happy the patients are, because that doesn't show up in a clinical trial. But I mean, they're hugging me, they're smiling, this is the best thing. Just totally positive reports.
Yeah, I've had patients buy the whole office like coffee and donuts because they just were so happy to not have to, especially if I got them off one of the newer, medicines that doesn't have as much coverage, that was costing them $200 a month. They're like overjoyed.
Yeah.
So, and I do the same thing, after 6 months, if they're still hanging on, and I'm just like, well, let's see you in 3-4 months. And then I'm always doing, some kind of testing to verify. Cause pressure is not that's only half the picture, right? Not even half the picture. I mean, you got to see what their nerve is doing, so I make sure that, I'm doing, a visual field, a fundus photo, a disc photo, an OCT, and, comparing it, and honestly, one of the things I do as well is I'll rent the patient an iHome tonometer for a week if they're willing, to kind of see what their diurnal curve is doing, and then I might do that before I've actually decided to do Durysta on a lot of these folks who pressure was always 15, but they were kind of getting worse, and we're like, what's going on, and I proved that they had, that the pressure was 25 at 11 p.m. And I'm like, hey, look, we need to be more aggressive. And so that's a whole other discussion, obviously, but I think that's a whole other window. The patients that the pressures are always seem to be fine. And they're like, well, why would I need to do anything else? Or why am I getting worse, doctor? Well, here's why. And we need to be more aggressive. And that's either SLT or Durysta or something, but you got to do something. And so I've had a ton of people that I've done Durysta on in that scenario as well. Because you never know if it's just a compliance issue too, that they're having that broad fluctuation. Or it's a function of eye drops. Diurnal curve is a function of being on eye drops too.
We have a bolus at nighttime.
Right.
We do know that, absolutely. Hey, real quick, I'm just curious for my sake. Are you guys, anyone doing it at the ASC or at the time of a standalone MIGS, or are you doing it all at the office after before MIGS? Anyone do it at the same time?
I have Durysta clinics. Actually, it's Durysta laser clinics, and so I'll walk back and forth between my laser room and the room that I do Durysta in. And so that just makes it more efficient because I'm not going to buy a second laser in my office, so And so that actually has been great, as I'll just bounce back and forth. It's been super efficient. And you can also just do them during the day, because it takes less time than an office visit.
Yeah.
But I like to have everything ready and have my text be in Durysta mode, and that's been really awesome.
Yeah, I do it throughout the day, but I have a couple of techs who are trained to kind of clean up the eye, get everything sterilized. We do it in the office in our slit lamp. We have a nice kind of slit lamp camera where the family can watch, et cetera, a nice TV. But so when I get in there, everything's all cleaned up. I just put my gloves on and bam, bam. I do like Nate, both eyes the same time. That way they come back in a month if they're doing well. Come back in 6 months, you're done, right? Yep. At the same time, there you go. That I want to see. Both hands, double fisting at one time. If you can show me that video, Nate, I'll give you $10. But just so from a cost perspective, and just so doctors are aware, you do lose that half that CPT code reimbursement for the second, right, Nate?
You do, and nothing happens with the injection reimbursement. That's the same, doesn't matter. But yeah, you lose a little bit on that second injection code, and
CPT code,
that's just my gift to my patients, to my Durysta patients.
Giving back, man. I love it. I love it. This idea of drug delivery is look, we have a lot of companies coming out with this. I think those doctors are not sure yet. Look, you have companies like Glaucoma with their iDose. You have companies like Oca Therapeutics with their travoprost implant, Madi Therapeutics. There's a number of others that are working on punctal delivery systems, et cetera. So I think we are on this road of drug delivery and interventional mindset. It's this train that's left, and it's not coming back. So I think it's just this is a great time to get involved and learn more about it. And even drug delivery with the anti-inflammatory space. I mean, Nate, now you have talked about dextenzon and Dexacue. I mean, just real quick before you go. Are you incorporating those two as a glaucoma specialist in your post-op patients?
Yeah, you sustained anti-inflammatory.
Yeah, like Dextenza, Dexacue. I mean, are you doing those with the post-MIGS patients or post-TRAVs?
Okay, ready. I had a month of surgery where no patients took any drops after.
Yes.
Surgery. Yeah. And that means antibiotics, NSAIDs, and steroids. Some of them still stayed on some glaucoma drops, but I've arrived and I use a combination of basically Trimoxy, Dextenza, and Dexacue. But I've been feeling empowered in that setting now, and I'm loving the outcomes. And I can do it with any insurance. I can do it with any scenario. Like, I'm there. I'm thrilled about it. Topic for another day. But this whole it's going to happen with everything. Eye drops are not the best way to get medicines in or around the eye. Period. Sorry.
Well said. Well said. Any last comments, Steve? Nate? I mean, this was so much fun, dude. I loved hanging out with you guys. I miss you guys. Any other comments, Steve, you want to make before we let everyone go?
I just think, I think it's a real blessing that we can have this conversation and we can get people to think differently. And that, we're not shaking things up to shake things up. We're doing it because we believe in what we're doing. And I really believe that every ophthalmologist that takes care of patients with glaucoma, if you haven't adopted or started doing sustained release bimatoprost, you really are you're at the point where you really need to explain to yourself why, because this is an opportunity to help your patients, and if you're not doing it, you really need to strongly consider why that is. People, they struggle to do things they didn't learn in residency, and I know it's difficult to do things, but you just need to pick a day and do 5 of them in a day and get over that hump, and then see how your patients do, and you'll be amazing. You'll be amazed at how this is such a great opportunity for your patients, and don't let this opportunity go. You'll find the patients once you get started. You'll see.
Nice. Nate, any last comments?
No, I think, Paul, to your point, I thank all the companies that are working in this space because it's a gift to patients and doctors. We didn't mention Allergan has ongoing studies. This has been 15 years for them, and they're just at the beginning. They're working on label extensions, and I'm sure maybe even other formulations. Who knows? But this is just it's a gift that I think these companies have listened to doctors, explain the problems their patients are having, and we're gonna have better outcomes. And I think that's coming. The data that shows that a 21 on drops is worse than a 21 on sustained delivery because of the nature of the pressure loading, the dynamics, and all that. And we'll get that data. I can just tell you it's coming.
I mean, we see that with MIGS, with the Height Horizon trials showing less chance of needing incisional surgery. I mean, we're seeing that now, and compliance is probably an issue, which is why I think, for me, in my perspective, I think I would leave everybody with this thought of, what is controlled glaucoma? What is uncontrolled glaucoma? And to me, controlled glaucoma is not just field stability and optic nerve stability. Is my patient able to stay on medications long-term with his current therapy? And if they're not, that's uncontrolled glaucoma. And I put that on my chart. I think we got to think about that. And that's part of why I think a lot of our patients are getting worse in our hands. And it's just, we get fooled, this whole structure function thing, man. I've had way too many patients where I've been complacent. I'm like, damn it. They come back. I'm like, I missed that huge arcuate defect now. So, but no, this was great, guys. I just want to say thank you for hanging out with me and letting me chill out and learn from you guys. You guys are awesome. Hopefully the next meeting we'll have fun. MIGS Mafia, Steve. Nate, you were in the MIGS Mafia video. If not, we got to get you in that one. Steve, you got to give him a shirt.
We need to make another video, maybe.
You're a drunk European dude.
Yeah, I think, I think, but we, the made men know, the made people, because there's women in the MIGS Mafia too,
MIGS people.
Actually, there's some of the most courageous folks. Yeah. So we need to, we are brothers and sisters together in a common with a common cause, and it's really to help our patients. There's a person behind that number that we're taking care of, right? And that's in the end, this is what this is all about, is us trying to help them.
Well,
so thanks for we sharpen each other and we make each other better. And things like this are just fantastic. Thank you.
Well said. And that note, I think that's the best way to stop it. Thanks everybody out there. Hopefully stay tuned for another edition of Dose and Delivery coming your way next quarter. But thank you again for taking the time to hear us out. Take care. Stay safe.
Thank you for tuning in to this episode of Dose and Delivery. If you have feedback or topic suggestions to share, find us on Glaucoma Today's Instagram, LinkedIn, Facebook, or Twitter. Stay tuned for more hot topics in glaucoma care on
Dose and Delivery.